Intraoperative aqueous misdirection syndrome by Dr. Dennis Gong, Eye Specialist Center, Kuching. I have no relevant financial disclosure. Aqueous misdirection is a challenging form of secondary angle closure glaucoma that presents with elevated pressure and shallowing of the anterior chamber despite the presence of a peripheral iridotomy. The condition was first described by von Graffy in 1869 and using the phrase malignant glaucoma because of the challenging nature of management of the disease and also the grave prognosis. Aqueous misdirection classically occurs during the early post-operative period after incisional surgery for angle closure glaucoma with an incidence described as of 0.6 to 4%. Aqueous misdirection can also occur intraoperatively, and the risk factors are shorter axial length, angle closure glaucoma, and also problems with the zonules, which allow the aqueous to travel back through the zonules into the vitreous cavity. The exact mechanism of the aqueous misdirection is unknown, but is thought to be due to aqueous directed posteriorly, resulting in positive vitreous pressure and then leading onto a flat anterior chamber and angle closure, and finally a rise in intraocular pressure. She is a 73-year-old woman who presented with left acute glaucoma and intraocular pressure of 40 on the 25th of February 2021. She was hypermetropic and had a short axial length of 21.26 mm. Laser PI was done bilaterally when the intraocular pressure was reduced after medical treatment. Subsequently, the intraocular pressure was still 20 despite being on Ganford. Therefore, left phaco and implant surgery was scheduled on the 10th of March 2021. Phaco and removal of the nucleus was done successfully, but during INA, the AC was progressively becoming more shallow and associated with iris prolapse and a hard eyeball on palpation. If there is a dark shadow, it is indicative of a choroidal hemorrhage, and the best option is to abort the surgery at this stage and come back another day. After excluding a choroidal hemorrhage, it was decided to proceed with the surgery, and a marking of 3.5 mm from the limbus was done. A VL trocar was then inserted at 3.5 mm from the limbus in the direction of the optic nerve. Vitrectomy without irrigation was then initiated, and the eye palpated to make sure that it's softened and also the AC has deepened. The prolapsed iris was then repositioned and the AC deepened with viscoelastic. A one-piece IOL was then injected into the back and then down into position. INA was done to remove the OVD and also the remaining residual cortex. More INA was done, and including going posterior to the lens to remove the OVD and also residual cortex. Injection of intracameral Vigamox at the end of the surgery. Photos of the right and also the left optic disc showing significant cupping and atrophy of the left optic disc. Post of 1 month showing normal right visual field and tunnel vision on the left and right visual acuity of 6/7.5 in the right and also the left eyes, and intraocular pressure of 13 and 14 in the right and left eye respectively with no glaucoma drops. Important intraoperative strategies are early recognition of the misdirection when it occurs during cataract surgery, and the signs to watch out for are if the iris keep prolapsing, anterior chamber is shallowing and increasing rock-hard eyeball, suprachoroidal hemorrhage, and also eye face syndrome has to be excluded. Preventive steps that can be taken to prevent aqueous misdirection are positioning of the head above the body to reduce the risk of posterior pressure from the weight of the body, to lessen posterior pressure by elevating the eyelid speculum, minimizing manipulation, and also creating a longer tunnel for the corneal incision to prevent iris prolapse, using a heavy viscoelastic to maintain the anterior chamber, and also gentle inflation of the anterior chamber with BSS. Acknowledgement, iWiki and American Academy of Ophthalmology. Thank you very much for watching.